Sir, we can't hear you. You need to unmute, sir. Dr. Somani, please unmute, sir. Yeah,
I
now it's
unmuted.
right.
Am I
Yeah,
audible
please,
now?
sir.
Yeah.
Yes, sir.
Yeah. So thanks once again. Good evening to all of you. And I welcome all the faculties, all the participants. And as you rightly said that how long we can keep chemotherapy away in the breast cancer, especially the metastatic breast cancer. The concept of sequential hormone therapy in the metastatic breast cancer is not a new concept. We used to give one line, second line, up to third line of the hormone therapy before we used to take them for the chemotherapy or other modalities of the treatment. But usually the second line or third line hormone therapy were not giving us the meaningful difference in the PFS or the overall survival. With the advent of the manipulation of the hormone resistance with the second line or third line, and now with the even the first line, now we can have the overall survival improvement also, we can have the overall improvement in the PFS also right from the beginning. So we have the CDK4 inhibitor to manipulate the aromatase inhibitor or the fulvestrant. We have now the mTOR inhibitor to manipulate the everolimus and the other drugs. And now we have the more and more drugs to manipulate the fulvestrant and maybe the letrozole also. So that means that the single agent hormone therapy probably is in the backbone in the hormone therapy management of the metastatic breast cancer, and with the partner drug, more improvement is there. So to have that in-depth discussion for today, we have the 2-3 talks on this particular concept. And for today's meeting, I invite our chairperson, Professor Hemant Malhotra, and the Director of Oncology Services at the Mahatma Gandhi Institute of Medical Sciences, Jaipur, and Professor Dr. G.S. Bhati, Medical Oncology at the Jodhpur Medical College, MGH Hospital. And with this, I hand over the mic to my esteemed chairpersons to start the proceeding. Thank you.
Thank you very much, Naresh. On behalf of my co-chairpersons, Dr. Girdhar Singh Bhati, my very dear friend for several years, we'd like to welcome you to this program on hormone receptor positive, HER2 receptor negative, advanced breast cancer. So we have 3 introductory and background talks in this program, and this is going to be followed by a panel discussion in which Dr. Lalit Mohan Sharma will tease out the pragmatic use of the new drugs which we have available now. So it is my pleasure to invite and welcome and introduce you to Dr. Deepak Gupta. Deepak is a senior medical oncologist in Jaipur. He did his DM in medical oncology from the prestigious AIMS Delhi. And in the next 10 minutes, Dr. Deepak Gupta is going to take you through the treatment landscape of HER2 positive advanced breast cancer in India, some data about our country. And after Dr. Deepak Gupta finishes, I'll request Dr. Girdhar Singh Bhati to take over and introduce the rest of the 2 speakers. So Dr. Deepak, are you there? The stage is yours now. You have 10 minutes.
Thank you, sir. So today's topic is treatment landscape of HR positive, HER2 negative MBC, Indian context. So this is a slide from Globocan, which shows that breast cancer is among the most common malignancies in India in females and both combined male and females. But there are some differences as compared to Western population in Indian population. Like we have a very younger population, less than 35 years of age, which is 8.1% as compared to 1.9% in Western population. And the median age of population is also a decade younger, 49 years in our country versus 61 year in Western countries. And not only age, but the biology of disease is also different. Like HER2 positive patients which are 3+ IHC, we have 16.7% as per TMS study, while it is 25 to 30% in Western population. ER/PR positive are 51% in Indian context, while it is 75 to 80% in Western population. Triple negatives, which are approximately 1/3 in Indian continent, but it is 11 to 15% in Western population. This is the stage distribution of breast cancer at 4 major cancer registries. Most of the patients fall in stage 2 and stage 3. So the treatment landscape of hormone receptor positive advanced MBC has been changing since 1970s, when we had tamoxifen, then aromatase inhibitors came, and then came the fulvestrant, then high dose fulvestrant. In 2010 onwards, we had era of targeted therapy, which were combined with endocrine therapy, and it included everolimus, then CDK4/6 inhibitors, and now PIK3 inhibitor. So initial treatment for majority of patients with HR positive, HER2 negative MBC should be treated with serial endocrine therapy based regimes, generally in combination with targeted therapies. Chemotherapy is usually not recommended for HR positive patient unless cancer has progressed through multiple lines of endocrine therapy or there are signs of visceral crisis. So treatment considerations include the sites and extent of disease, organ dysfunction, prior systemic therapy for early breast cancer, length of disease-free interval, rate of disease progression, presence of BRCA1, BRCA2 mutation, then comorbidity and quality of life. So this shows that combining targeted and anti-estrogen therapy can overcome the resistance in hormone receptor positive advanced breast cancer. Approximately 1/3 of hormone receptor positive MBCs are de novo resistant, but other mechanism of resistance include loss of or alteration of ER expression, overexpression or activation of GF receptors, or activation of downstream signaling transduction pathways. So these targeted therapies like mTOR inhibitors and CDK4/6 inhibitors act on downstream signaling pathway. So these are the phase 3 clinical trials with CDK4/6 in combination with non-steroidal and aromatase inhibitors in first line setting. First is Mona Lisa 2, which is ribociclib with letrozole versus placebo. Then Paloma 2 is palbociclib plus letrozole versus placebo plus letrozole. Monarch 3 is for abemaciclib plus non-steroidal aromatase inhibitors, and Mona Lisa 7 is for premenopausal or perimenopausal females, ribociclib plus tamoxifen or aromatase inhibitors. And these are the studies which had fulvestrant as hormone therapy partner along with CDK4 and 6 inhibitors. So Mona Lisa 3 had a fulvestrant with ribociclib as a partner drug, and Paloma 3 has palbociclib plus fulvestrant, and Monarch has had abemaciclib plus fulvestrant as a drug partner. There was OS significantly OS benefit in Mona Lisa 3 and Monarch 2. And there is a significant benefit in PFS also in first line setting. You can see that Paloma 2, Mona Lisa 2 and Monarch 3. These are all first line studies. They all have equal, more or less equal hazard ratio of 0.54 to 0.56. And PFS is approximately the same, 27 to 28 months as compared to 14 to 16 months with hormone therapy alone. And overall response rates are also similar. When we talk about premenopausal or perimenopausal female as seen in Mona Lisa 7 with ribociclib, hazard ratio is also similar, 0.55 with similar kind of PFS and response rates. And when we talk about second line setting, CDK4/6 inhibitions, then second line also the PFS is 11.2 months in with palbociclib, 16.9 months with abemaciclib, and 14.6 months with ribociclib, which is way away from the hormone therapy alone. But there are differences in patient populations and patient selection criteria in all these three studies. So there are subtle differences in the response rates and PFS, because in Monarch 2 only one priority was allowed, while in Paloma 3 trial more than one prior CT or endocrine therapy was also allowed. So there are overall survival advantage in Mona Lisa 7 in first line setting also, 29% relative risk reduction of death. Median OS was not reached versus 40 months. And in Monarch 2 also there was overall survival advantage of hazard ratio of 0.75 and 9.4 month overall survival advantage seen with abemaciclib. When we talk about toxicities, so neutropenia and anemia is a class effect which is seen by all three CDK4/6 inhibitors. While diarrhea and nausea is more common with abemaciclib, infections and thrombocytopenias are more common with palbociclib. while QT prolongation and increased LFTs are more seen with ribociclib. When we talk about Indian data, there is a one abstract which was published in JCO this year. So they had the data of 133 patients, out of which 83 and 62.4% of patients were first line setting and 37.6 were 0.6% were second line setting. Among first line patients, 55% were de novo and 45% were post adjuvant relapse. Bone metastases were seen in only in 45% and visceral metastases were seen in 54% of patients. Median age was 56 years. Among first-line patients, the majority of patients had letrozole as a drug partner, hormone partner. 18% had fulvestrant and 6% had exemestane. Among second-line patients, most of the patient has had fulvestrant as a hormone therapy partner, followed by letrozole and exemestane. Overall response rates were 71% in first line and 52% in second line. But 60% of these patients in second line had a chemotherapy. When we talk about progression-free survival with a median follow-up of 18 months, among first-line patients, it was not reached for de novo MBC patient versus 18 months for post-adjuvant relapsed patients. And when we talk about disease volume or burden, then it was not reached, PFS was not reached for bone-only disease as compared to 28 months for visceral disease. When we talk about second line, median PFS was 14 months. And it was 14 month and 13 month for both bone and visceral disease. So there was not much difference in second line setting with respect to disease burden. Then we have Bolero 2 data, which is everolimus along with exemestane in hormone receptor positive disease, which are progressed on hormone therapy alone. So exemestane plus everolimus versus exemestane plus placebo. So PFS was 7.8 month versus 3.2 month by local assessment and 11 month versus 4.1 month by central assessment, which is quite significant, approximately 60% risk reduction in for relapse. And final OS was also 31 month versus 26 month, although that was not very significantly different. When we talk about adverse effects, so everolimus has more of toxicities like stomatitis, rash, fatigue and diarrhea and nausea and decreased appetite. Some patients do have hyperglycemia also. There is an Indian data by Jyoti Bajpai in Indian Journal of Cancer 2016, which was a retrospective analysis of 41 MBC patients recurring or progressing on aromatase inhibitors and treated with everolimus with either fulvestrant, aromatase inhibitors or tamoxifen. Median age was 55 years, 73% had visceral metastases and 73% had received 3 lines of therapy including chemotherapy. So median PFS was approximately 22 weeks, which is 5 months, and its range was 3 to 76 weeks. There was no CR, but there was 1/3 patient has PR and 1/3 patient approximately had stable disease. So clinical benefit rate was, including CR, PR and stable disease was 68%. And when we talk about toxicity, these were more or less same as in Bolero trial, like oral mucositis, new onset hyperglycemia, transaminitis, new onset dyslipidemia, and then anemia and fatigue. These were the more common toxicities which were seen with everolimus, and 31% required dose reduction for everolimus too. So to conclude my talk, so increasing use of CDK4 and 6 inhibitors in India is seen nowadays. Outcomes are fairly compared with the Western population and Western data, but there is limited data from Indian subcontinent, although cost remains an important issue. Thank you. Over to you, Malhotra sir.
So may I request Dr. Bhati to take over and introduce the next speaker, Dr. Girdhar Singh Bhati. Girdhar, are you there? Is Tarun, is Dr. Bhati online?
No, sir. He's there. Yeah, he's there. Dr. Bhati, sir, can you hear us? You need to unmute. Dr. Bhati, sir, you need to unmute, please.
Okay, so in the interest of time, maybe I can introduce the second speaker and Dr. Girdhar Singh Bhati can introduce the third speaker and then he can conduct the panel discussion. Will that be okay, Naresh?
Yes, sir. Yes, sir.
All right. So it's a pleasure for me to introduce Dr. Surendra Beniwal. Dr. Beniwal is the Chief of Medical Oncology at the Acharya Tulsi Cancer Center in Bikaner, the regional cancer center which we have in Rajasthan. And Dr. Beniwal is going to speak to us on the overall survival advantage which one of our new agents, one of our CDK4/6 inhibitors, which is now producing for patients with hormone receptor positive, HER2 negative breast cancer. So I hand over proceedings and the next talk to Dr. Surendra Beniwal. Dr. Beniwal, you have 15 minutes. Are you there, Dr. Beniwal?
Yeah, yes, sir.
Okay.
Thank you very much, sir.
The forum is yours.
Thank you very much, sir. Can you see my screen? Hello.
Yes, sir.
Yeah. Okay. Thank you very much, sir. I'm Lotra, sir. And today's my topic is on overall survival in HER2 positive advanced breast cancer from dream to reality. And we all know that the most of advanced breast cancer and metastatic breast cancer are not curable. So our aim is to treat their symptoms and to increase their life, but not on the basis of very severe toxicity. So we all prefer endocrine therapy in especially hormone positive breast cancer. And because these endocrine therapies can decrease the tumor burden and the symptom.
Arun, what happened? What's the problem?
Yeah, there is problem in screen. So,
Yeah.
Yeah, I understand.
So you just have to say next, and next. That's it.
Okay. Next. So our goal of treatment in advanced and metastatic breast cancer, especially hormone positive breast cancer, is to decrease their symptom and increase their life with a very good quality of life. So most of cancer physicians nowadays does not use chemotherapy, and our main treatment is endocrine therapy with either alone or with various type of targeted agents, and more various modern targeted agent as already described by the Dr. Deepak, that they increase progression-free survival as well as possibly some survival benefit also compared to the older endocrine therapy. So next. And this slide shows some history of survival benefit in hormonal therapy in endocrine positive, ER positive breast cancer. So first of all, when we used tamoxifen and the overall progression survival was 5.6 months. This was approximately double after the introduction of AI, approximately 11 months, and which was again increased 4 to 5 months after the introduction of fulvestrant. And all these agents are working either directly on the ER receptor, or they can downregulate ER receptor, or they decrease the estrogen level. So there is we reach a peak of approximately 16 months with the help of these agents, either alone or in combination. So we need more targeted agents which can be used either alone or with these endocrine therapy, and that can increase survival benefit in these type of patients with minimal toxicity. And with the we all know that we can use various combination with different mechanism of action or drugs. So there is introduction of newer agents which was found in the pathway between endocrine receptor as well as nucleus. So the various type of targeted agents are come next. So there is introduction of various target agents. First of all is the CDK4/6 inhibitor. We have available 3 type of drug: palbociclib, ribociclib, and elbiciclib. We all know that the CDK4/6 inhibitor, CDK4/6 act as a growth of the cancer cells with the inhibition of RB gene. So we use CDK4 and 6 inhibitor when there is resistance in the endocrine therapy, or we can use with these endocrine therapies, so we can increase the survival. And various other mechanism, PI3K, AKT, mTOR signaling pathway, which is also come in between the ER receptor and the nucleus. So when there is mutation in these receptors, then there is development of resistance. So these agents come in scenario to increase to overcome the resistance of these endocrine receptors and endocrine therapies and increase the survival. Next. So first of all, when these targeted agents are come, why we use these targeted agents in first line? There is a very large meta-analysis which was published in Lancet Oncology in 2019. In this, they include 140 randomized trials and enrolling approximately 50,000 patients. In this, they took either in the first line trial or the second line trial, and they took either AI alone with the targeted agents or AI alone with targeted agents, comparing with the chemotherapy. And what they found that when AI is used with various type of targeted agents, including CDK4 inhibitors, PI3K inhibitors, and mTOR inhibitors, they found approximately 0.4 hazard ratio for the progression-free survival, which is a very good for surrogate marker of the overall survival. So with the meta-analysis of this trial, it was clear that when we have to use first line as endocrine therapy with targeted agents, either CDK4, mTOR inhibitor, or PI3K inhibitor if there is mutation in the PI3K mutations are found. Next. So we all know that the CDK4/6 inhibitor is oral agents and less toxic than all these other agents. So the CDK4 inhibitor was preferred agents with the targeted agents, but we don't know which type of the backbone of endocrine therapy will be used with the CDK4 inhibitors. And for this, there is a Parsifal trial was done. In the goal of the Parsifal trial to determine the optimal endocrine backbone in combination with the palbociclib in the first line scenario. And next. In Parsifal trial, what they do, they include ER or PR positive metastatic breast cancer with no prior therapy for the advanced breast cancer, post-menopausal or medically castrated premenopausal women, and they took only endocrine sensitive, and the criteria for endocrine sensitive was a relapse after the 12 month, or they are endocrine naive, and they use fulvestrant with the palbociclib, or they use letrozole with the palbociclib. And what next? And what they found that there is no progression-free survival benefit or overall survival benefit of the fulvestrant. Next slide. Or the fulvestrant in palbociclib with the palbociclib. So they found that the fulvestrant is an invasive drug, but there is no benefit in the progression-free survival and overall survival. And so the results are inconclusive, and the treatment decision for the backbone of endocrine therapy depends on the patient and the clinical and the clinician. So each of the patient, either they want to injection monthly or they want the daily tablet. So the backbone we can use either AI or fulvestrant as in the first line therapy. So no superiority of fulvestrant was found in this. Next slide. So based on this Parsifal trial, we can use CDK4 inhibitor with the AI, because these we use all the oral tablets in spite of the fulvestrant. And another question is that are any subgroup of the patient who should definitely receive CDK4 inhibitor upfront, or there are any subgroup in which we can continue CDK4 or 6 inhibitor beyond the progression. So for this, we need some biomarkers which predict the CDK4/6 inhibitor activity or CDK4 activity in the cells. Next slide. For this, they did some various type of studies, and one study in Monarch 3 in which they used the acquired ESR1 alteration, which is a resistant mechanism for the endocrine therapies. And what they found that the acquisition of ESR1 alteration is less commonly found with the abemaciclib with AI in spite of the placebo plus AI, but they found that the median progression-free survival with or without ESR1 alteration was similar if in the abemaciclib, while it was longer in the patient with the placebo with AI. This indicates that the ESR1 alteration was come in the cells when there is a prolonged survival. So we can use this ESR1 alteration as a surrogate marker for CDK4 inhibitor. Still, this is not a approved marker. Next slide. So there is still no biomarker available to the clinical practice nowadays for CDK4 inhibitor activity, predict the activity of CDK4 inhibitor. ESR1 mutation status may be a nearest term opportunity. Next slide. And this table shows some difference among these three CDK4/6 inhibitors, which was already described by Dr. Deepak Gupta. And approximately all three these CDK4 inhibitor has the same effect, approximately same progression-free survival with somewhat different toxicity profile, and we can use according to the comorbid wellness and the patient's status. So the neutropenia is more common with the palbociclib, while diarrhea is more common with abemaciclib, and the QTc prolongation is more common with the ribociclib. So if any cardiac patient, so we have to avoid ribociclib, and if patient is already treated with the various type of chemotherapy and frequently develop neutropenia, so we in this we can use another agent, abemaciclib or the ribociclib. And the fatigue, which is a very important factor, because we all know that these old patients are stage 4 patients, and the quality of life is very important. So the fatigue is more common in palbociclib. So if patient has a fatigue, so we can use ribociclib or abemaciclib, because fatigue is the most important side effect for the patient, because fatigue patient cannot live normal life with the fatigue. Next slide. And these some trials which was already described by the Dr. Deepak Gupta. In the first line, Palma 1, Palma 2, and Mona Lisa 2, and Monarch 3 and Mona Lisa 3. In this shows the approximately same hazard ratio from 0.5 to 0.58, and approximately same progression-free survival, approximately 30 to 40% increase in progression-free survival. So all three CDK4 inhibitor are approximately same in function. We can use according to the choice of physician and availability of these drugs. Next slide. This table shows in the second line with the fulvestrant, and in this there is also approximately same progression-free survival benefit. But in Monarch 2 and in Mona Lisa 3, we were found the overall survival benefit, which was not found with the Paloma 3, which most probably due to the there is a lesser patient, and the trial is not in adequate patients to show the overall survival benefit. Next slide. So the initial report demonstrated that no improvement in the survival benefit. But why there is no improvement in survival benefit? These three drugs, there were main three issues. First is the survival is prolonged in these metastatic breast cancer, and the event takes time to see these. So we need more time to see the overall survival benefit. Second, the studies were generally underpowered for the survival, and but the overall survival benefit is a matter because all other are surrogate markers. So we need survival benefit, and we found survival benefit in 2 trials. Next slide. Next. In these 2 trials, Mona Lisa 3 and the Monarch 2, we found survival benefit, and these survival benefit are most probably due to the carryover effect of these drugs even in the further lines of the treatment, like in tamoxifen. And in Mona Lisa 3, we find survival benefit which is statistically significant with a hazard ratio of 0.73, as well as in Monarch 3, we also found survival benefit, overall survival benefit 49 months versus 39 months. Next slide. So the summary for CDK4 inhibitors, all AI in combination with CDK4 inhibitor remains the standard of care for the first line. Fulvestrant does not show to be better than the aromatase inhibitor when combined with CDK4 inhibitor in the first line. There is no biomarker to predict the response of CDK4 and 6 inhibitors. And in Monarch 2 subgroup analysis, there is combination of fulvestrant and abemaciclib shows superior fulvestrant along with the first and second line of drug, and the quality of life data with the ribociclib and palbociclib reassure their goal of the treatment. Next slide. And after either failure of these drugs or there is another mechanism which was described by the Somani sir in next topic. And these are also a mechanism of resistance, because we all know that the PI3K AKT-mTOR inhibitor is a pathway which is mutated in endocrine therapy resistant. And when these drugs are mutated, then growth of the cancer cells are independent of these estrogen, and without estrogen they can grow. And so with the endocrine therapy there is a resistance. So we have to target these agents, and there are 3 agents which are available for mTOR inhibitor: everolimus, for PI3K, alpelisib, and AKT, capivasertinib, which is not available nowadays, which is in under trial. So we can use these drugs to overcome the mechanism, resistance mechanism for these targeted agents. Next slide. And the importance of PI3K pathway in hormone-positive breast cancer is that it is frequently found in resistance of the endocrine mechanism, and approximately 40% of hormone-positive breast cancer found PI3K mutation, which leads to hyperactivity of this PI3K pathway, which is a very large number. And due to these mutations, there is estrogen-independent growth of ER receptor breast cancer, and this growth is inhibited by addition of PI3K inhibitor to the estrogens. Next slide. And this trial is important, especially for our Indian scenario, because AI with the targeted agents is a cost-share therapy for all of our patients. So the fulvestrant can be added with the anastrozole. If this trial is successful, then our poor patients can also take benefit of combination of these 2 endocrine therapies. And there are 2 trials. There are many trials for these, and there are controversial results. Some trials shows some benefit, and another trial shows no benefit. There are 2 main trials. One is the SWOG trial. In this, they found progression-free survival as well as overall survival benefit with the combination of fulvestrant plus anastrozole, compare with either fulvestrant or anastrozole. While the FACT trial has opposite results, they did not found any improvement with the combination of these 2 agents in spite of the single agents. And the different results of these trial are most probably due to that the in SWOG trial they took all metastatic patients. In spite of the FACT trial, they took also advanced breast cancer. Second one, in SWOG trial, they took all patients are endocrine naive, while in the FACT, they also took some patients with have progression of patients in the some type of endocrine therapies in previous therapies. So we need a larger trial in the theme of SWOG trial. So if this trial is successful, then we have some cheaper option with some survival benefit for the Indian poor patients. Next slide. So my concluding remark is that although we all know that the advanced breast cancer and metastatic breast cancer is unlikely to be cured, but there is a meaningful improvement in the survival due to availability of more effective and less toxic systemic therapy, especially CDK4 inhibitor, which is still continue to improve the outcome and long-term with the long-term follow-up. And no biomarker is currently available to predict the action of CDK4 inhibitor. For second-line inhibitor, we also consider the other targeted agents and do the test for PI3K mutations in all patients who have failure on second line, because approximately 40% patients have PI3K mutations. And we prefer these tests on the tumor. If the tumor is not available, then we can do this with the help of liquid biopsy. Next slide. And in patients with the tumor who have a mutation, PI3K mutation, then we can use fulvestrant plus alpelisib in associated with the improved progression-free survival to the fulvestrant, and the hazard ratio is approximately 0.4 as the same in other type of targeted agents. And we can also use everolimus as in Bolero 2 trial, and there is no need of PI3K mutational status for this. And one new drug which is also come in scenario with the AKT inhibitors, which is also some promising results, which is also discussed with the by the Somani sir. And so my conclusion is that we move to the more personalized therapy for metastatic estrogen receptor positive disease, and multiple new drugs are continue to come including antibody drug conjugates. So we can increase the life of these women with good quality of life, with very less toxic agents and very less invasive agents, with help of various oral drugs. Thank you.
Thank you very much, Dr. Beniwal. That was a wonderful talk, comprehensive coverage of the availability of the new agents. And I think we'll do all the questions during the panel discussion. I have a question to the organizers. Is Dr. Girdhar Singh Bhati available? Can he take over now? Dr. Bhati, are you there? Girdhar, can you connect?
Am I audible?
Yes, you are audible,
Am I
sir.
audible? Am I audible? Am I
Yes,
audible?
Girdhar,
yes,
we
you
can
are
hear you.
audible.
Just
Okay.
come closer
Okay.
to the mic and then take over, please. You have to introduce the
Okay.
third speaker and then
Okay.
do the panel discussion. Okay? Thank you.
Okay. Good evening to all of you. And our next speaker is Dr. Naresh Somani. He's a quite eminent and the leading medical oncologist of the country, and he's from Bhagwan Mahavir Cancer Hospital, Jaipur. And he will talk on the picking the right strategy for the treatment of with TCA mutate hormone positive, HER negative advanced breast cancer. Over to Dr. Naresh Somani. Go ahead for the talk.
Thank you, Professor Bhati, for the nice presentation. One thing which I have learned from these webinars, that more and more webinars you do, your introduction will increase. Professor Malhotra used to call me the eminent, prominent doctor of Jaipur. Now Dr. Bhati is calling me the prominent doctor of the country. maybe next time, I don't know how you will introduce me.
Yes, you are. You are.
But you are
actually
you are.
You are. Really you are.
Naresh, my apologies. Next time onwards, if I get the opportunity, then you will be the most prominent oncologist in the world, international fame.
Dr. Professor Malhotra sir is securing his position as the introduction for the talk, for the chairpersonship, for the moderatorship, for the talk, and for the concluding remarks, so that you always get the best introduction. Am I correct, sir?
Absolutely correct. It's the most comfortable position to be, the chairperson. कोई तैयारी नहीं करनी पड़ती, कोई slide नहीं बनानी पड़ती. Best position.
Yeah.
Thank
With
you.
these light moments, can I get my slides? Yeah. So as we are passing through the journey of the management of the metastatic breast cancer, and the previous speakers, Dr. Deepak Gupta and Dr. Surendra Beniwal, they were talking about the Indian data, about the CDK4 inhibitor, and then how the first line and second line treatment are there. And now we have the understanding of the one more mutation in this particular scenario, and how it is being manipulated, and how the new drugs are coming. So now we can in real sense say that, like the NSCLC, TKI drugs, first line, second line, or subsequent line sequential treatment, probably now we have the same sequential hormone therapy in the metastatic breast cancer. And with the availability of the alpelisib on the horizon in this thing, I think the perfect scenario is there. For the sequential treatment of the metastatic breast cancer until patient goes in the visceral crisis. So next slide, please. So we understand now the importance of the PI3K pathway. Two terms are there, that is the PIK3 mutation and the PI3K pathway. So that is very important to understand. So it is the PI3K, AKT, mTOR pathway. If you downstream understand, we have the drug like the mTOR inhibitor, we are now having the drug like the AKT inhibitor. If we start right from the PI3K mutation upstream, then we can develop and design the drug here also. So approximately 40% of the hormone receptor positive breast cancer, they have this mutation. Now, just to tell you that this mutation is not limited to hormone receptors positive patients also. It happens to the 10% of the patient in the HER positive patients also. It happens to the same tune in the triple negative breast cancer patients also. Now, this has been shown to promote the estrogen independent growth of the ER positive breast cancer. And this growth is inhibited now with the availability of the more selective drug, that is the alpha analogs of the PI3K inhibitors, the anti-estrogen. Next slide, please. So guidelines of the management of the hormone receptor HER advanced breast cancer, we understand depending on the visceral crisis, whether no visceral crisis, whether the patient is a premenopausal, postmenopausal, and same in the whether the patient has received one line of the therapy, and depending on the pre or postmenopausal patient, you decide whether the patient has the visceral mets, what is the burden of the disease, whether you want to give the single agent drug like the tamoxifen, or you want to partner the aromatase inhibitor or fulvestrant with the CDK4 inhibitor. And as you progress with the patient, the further subsequent progression of the disease, then we again try to partner the subsequent drugs with either with the mTOR inhibitor or now preferably with the PIK3 mutant inhibitor drugs. Next slide, please. The targeting upstream versus downstream in the PIK3, the interesting concept to understand. Higher we block the pathway, probably more selective, more pan inhibition of the proliferation, signaling, transformation, metastasis, and this all we will have. And this has been now proven with the help of the alpelisib, combining with the fulvestrant and with the letrozole also. Next slide, please. So selective inhibition of the PI3K. PI3K concept is a not new. Previously, the pan inhibitor drug beparsib, they have been attempted in the breast cancer. We have been the part of the beparsib trial in the head neck cancer patients also, but that trial failed miserably because of a lot of toxicity, depression, suicidal tendency. And then we have the more selective drug to mitigate the toxicity. We have now the alpha blocker, that is the alpelisib, thoughtfully designed drug by the Novartis, and this trial subsequently progressed from the phase 1 to the phase 2, and then the SOLAR-1 trial, that is the phase 3 trial in the metastatic breast cancer. Next slide, please. So the SOLAR-1 is the phase 3 randomized double blind like any other trial. Male patient, postmenopausal women patient, metastatic breast cancer, hormone receptor positive, HER patient. This is a common scenario to treat the HER positive breast cancer patient. Now, interesting aspect is here that both the PIK3 mutation positive patient as well as the non-mutant patients were taken in this. This is very important to understand. So this was taken as the proof of the concept to say, to understand that this combination of the fulvestrant plus alpelisib is not by chance working. So to understand, is there any difference between the mutant patient versus not mutant patient? So the both groups of the patient were they randomized to alpelisib plus fulvi versus placebo, and then primary endpoint of this trial was PFS in the PIK3 mutant cohort. The secondary endpoints included like overall survival, PFS in the both group, and overall response rate, clinical benefit ratio, and the safety analysis. Obviously, next slide, please. So primary endpoint, if we look at the PFS, so obviously alpelisib plus fulvestrant, there is a huge difference. The graph starts separating quite early, within 1 month, and you can say that it persists, giving you the median PFS of 11 months versus 5.7 months. This is the group of the patient who are treated in the second line of the patient, and median PFS we can see here, hazard ratio is 0.65, and one-sided p-value is quite impressive. Next slide, please. So the best percentage ratio, if we look the slide, this particular trial in the other way, we can see here that the more and more patients in this particular group of the alpelisib plus fulvestrant have the more shrinkage of the tumor versus the placebo plus fulvestrant. So obviously this will translate in the more PFS and probably in the more response rate and more survival gain also. Next slide, please. So ISMO definition of endocrine resistance, this is a beautiful slide to remember that in the adjuvant setting, in the metastatic setting, how the hormone resistance is being labeled during the treatment. After 2 years, minimum 2 years of the adjuvant treatment, if the patient progresses, then we call it as the secondary resistance, primary resistance. If beyond 2 years, it's the secondary resistance. In the metastatic setting, if the patient progresses within the 6 months of the hormone therapy, the primary, otherwise we call it the secondary resistance. So this is very important to understand the next line of the treatment. Next slide, please. So if we look in this particular slide, this SOLAR-1 trial was initially designed to include the both hormone sensitive and hormone resistant patients also. So later on the trial was amended, and to have the more powerful impact of the outcome, the endocrine resistant patients only were taken. And here we can see that the quite since the beginning there is a difference in the KPS, and this remains throughout the a follow-up of the patient, and same happens in the second line treatment also. So this trial is now basically being focused on the endocrine resistant patients only. Next slide, please. So PFS by the prior CDK4/6 inhibitors, as we now understood, as the understanding given by my previous two speakers, that whether you take the letrozole or with the any three of the CDK4 inhibitor, probably these are the first line treatment. So maximum patient presently we will have those patients who are treated with the aromatase inhibitor with the CDK4/6 inhibitor. So obviously those patients who are now being treated with the fulvestrant plus PIK3 mutant patients, there are two important things which you need to remember. It gives you the benefit whether you have taken the patient with a CDK4/6 inhibitor or not. And second thing, the toxicity aspect of the alpha-LC with the fulvestrant doesn't change whether the patient has been exposed to the CDK4/6 inhibitor previously. Next slide, please. So locally assessed PFS by the tissue or plasma, this is very important because tissue is always a problem to take the repeat biopsy. Sometimes the sites are not amenable, it's a torture, patients are not willing. So the studies have been validated that yes, there is a 70% concordance. Plasma, if you want to do it, you can do it. It's a negative, go ahead with the tissue, try to take the tissue or try to take the tissue upfront. But yes, if you look at the various ways of analysis of this particular trial, those patients who has been exposed to this combination based on the plasma tissue, plasma based CT DNA positive of the PIK3 mutation, their patient respond equally how the patient respond to the tissue based PIK3 mutation selected patient. Next slide, please. So key secondary endpoint was the overall survival in the PIK3 mutant cohort. And yes, these data are not so mature enough, but we can see here that median overall survival in this particular combination is still not reached versus 26.9 months in the placebo plus fulvestrant arm. And this is seen across the various trials of the fulvestrant. And obviously this will be crossing, and I'm quite optimistic that this trial will give the survival outcome also in second line of the treatment also. Next slide, please. So results based on the treatment exposure. Now important aspect that every combination in the hormone therapy, whether it's the mTOR inhibitor, whether it's the CDK4 inhibitor, or whether it's the PIK3 mutation, will give the toxicity, added toxicity. So obviously we always try to reduce the dose of the partner drug, whether it's the mTOR inhibitor, whether it's the CDK4 inhibitor, or whether it's the PIK3 mutant inhibitor. So if we reduce it and we see the median dose intensity, which is approximately 248 milligram, we can see here clearly that even with the reduced dose, the benefit of this particular trial or this combination remains there compared to the single agent fulvestrant. So we should not bother whether we are able to maintain the dose or we are not able to maintain the dose. We should continue giving our patient alpha-LC, those who are the PIK3 mutate positive. Next slide, please. Next slide, please. So safety, yes, important safety. Three toxicity you need to remember in your day-to-day clinical practice. Lot of new drugs are coming. These drugs have sometimes the overlapping toxicity across the various molecules. Like three important, that is the new onset hyperglycemia. RAS is very important to remember, and diarrhea. Now, important thing is that these toxicities, especially the hyperglycemia and RAS, they come quite early during the onset of the patient. So you have to be very aggressive in managing and follow up and the education of these patients. Now, RAS is very important to understand. If you give the prophylactic antihistaminic drug, that is the non-sedating antihistaminic drug, probably the RAS will not develop. Hyperglycemia with the oral anti-diabetic drugs, it's easy to manage. Same way with the symptomatic treatment, you can manage the diarrhea also. Next slide, please. So I would like to conclude with this quick presentation. The SOLAR-1 met its primary endpoint, that is the statistically significant and clinically meaningful prolongation of the median PFS was observed with the addition of the alpha-LC, that is the alpha blockade of the PIK3 mutation with the combination of the fulvestrant. The majority of the patients in the study were the endocrine resistant after the trial amendment was done. Subgroup analysis demonstrated the benefit of the alpha-LC regardless of the lane of the therapy with the prior CDK4 inhibitor. Now we have the another trial for this particular group of the patient. Overall survival data at the first interim analysis in the patient in this particular mutation were immature. The median overall survival was, however, not reached in this particular arm. Hyperglycemia, rash, and diarrhea are the three common toxicity which can be managed. They are the early toxicity. Optimal treatment benefit is achieved by maintaining a high median dose intensity of the alpha-LC. Medically managing adverse events is required. Now, important thing which I would like to share with you, that yes, always we try to take the PIK3 mutation on the recent tissue, but this is mutation which is present in the breast tissue quite early. So if you are not able to get the fresh tissue, you can do it by the archival specimen also. And there are studies which say that yes, they are having the concordance, the incidence rate of the this particular subset of the patient, that is the HR positive, negative patient, is more or less matching. So you can sometimes take the archival tissue also to understand the PIK3 mutation, this patient also. And obviously ctDNA is also now available in Indian scenario also. Next slide, please. Next slide, please. And this just to give the brief outlook, that is the Bailey study, which is basically studying the two subarms of this study, that is the fulvestrant cohort, alpha-LC plus fulvestrant, and letrozole cohort, that is those patients who have been exposed first to the fulvestrant. And this is basically in those patients where the CDK4 inhibitor is given in the first line. This trial will hopefully will give us the answer that yes, whether the patients are treated with the letrozole first or with the fulvestrant first. If you partner them with the alpha-LC, we are going to have the benefit. And I need not to go in this particular trial right now in the interest of the time. And with this, I thank everyone.
Thank you, Dr. Naresh, for an excellent presentation. And I would like to ask you, because there is no question from chat box, I would like to ask, what is your experience with alpha-LC?
No, so far we don't have the mature experience. Recently, we just have started, but it's too early because these patients right now, if you understand those patients who can afford, obviously they are affording the CDK4/6 inhibitor, and maybe that when we will have the relapse patient or the progressive disease patient on the CDK4 inhibitor, then we will have the opportunity to get the exposure to this kind of the drugs. So as far as the tolerance, outcome, and oral experience is concerned, it's too early to comment on our own experience. Thank you, sir.
And what is regarding the hyperglycemia? Is it easy to manage in alpha-LC? People say it's very difficult.
Yeah. If we understand the hyperglycemia which we have with the ribociclib, which we have the drug like Tasigna, which we have the drug with the other malignancies where the hyperglycemia develops by like immuno-oncology drugs, I am quite comfortable managing them, and hardly we are able or switch. We require to switch to the insulin or readmit them or diabetic ketoacidosis. Most of the time, the double oral hypoglycemic agents, we are able to control the hyperglycemia.
Okay, thank you. Now I will request Dr. Lalit Mohan Sarma, who is the most humble, most lovely, and most bright medical oncologist from Rajasthan, and also eminent medical oncologist of the country. I would request him to invite this panel and go ahead. Dr. Lalit, please go ahead.
Yeah, thank you so much, Dr. Bhati sir, for your kind words.
Dr. Lalit, you would like to introduce all your panelists, or should I do it?
No, I think you can do it. It's in your part.
So, like you, all our panelists, they are well known to all of us, but it's always required to understand that what they have achieved, where they are working. So, may I introduce the first panelist, Dr. Sandeep Jasuja, medical oncologist, State Cancer Institute. He's a professor and head there, and superintendent also presently. Dr. Mukul Goyal, senior medical oncologist from the Metro Mass Hospital. Dr. Ajay Yadav, young budding medical oncologist. He is assistant professor at the Mahatma Gandhi Medical College at the Medical Oncology Department. Dr. Lalit Sharma, medical oncologist from the Manipal Hospital, Jaipur. Dr. Ankit Agarwal, we welcome Dr. Ankit Agarwal. He is from Gitanjali Medical College, Udaipur, medical oncologist with us. Dr. Jitendra Pelajani, young budding enthusiastic medical oncologist from the Selby Hospital, Jaipur. And we have our good friend, Professor Radiation Oncology, Dr. R.S. Gotwal from SMS Medical College. Welcome, Dr. Gotwal. And we have Dr. Sivank Mathur. He is a surgical oncologist from the Railway Hospital. And Dr. Uttam Soni, well-known figure in the field of the breast oncosurgery from Sita Devi Memorial Hospital, Jaipur. And with this, I go back to Dr. Lalit Mohan Sharma.
So thank you so much, Dr. Somani, and I'm happy that we will be having a very rich panel, and we will do justice to the case being discussed. So I'll start directly with the case. 50-year-old female, post-menopausal lady. She came to us in November 2014. She was detected to have CA right breast, T3N0M0. MRM was done, and it was ER positive, PR positive, HER2 negative. So chemotherapy was given, followed by radiation, and then she was started on anastrozole, and she was tolerating it reasonably well. For next 3.5 years, almost in Feb 2020, she developed progressive bone pain, and she was detected to have pathological fracture of right hip joint. And with this complaint, she was admitted with us. So we did a PET CT scan, which confirmed bone-only mets, and there was no visceral mets at this point. And looking to good general condition, bone-only meds, and the pathological fracture, we discussed with our ortho oncosurgeon, and we plan to undertake this lady for surgery followed by prosthesis implantation. So may I start with my panelists here that is it the right approach or you have another different idea? Well, I'll start with Dr. Ajay Yadav. Ajay, all this schema is good or you have some different school of thoughts to guide that? Anything else?
Sir, as the treatment-free interval is very high in this case, so I would like to repeat the biopsy. Because since 2014 to 20, there are 6 years.
Right. Dr. Jitendra, you also agree that we should do a biopsy at this point or can we directly go ahead?
No, sir. Biopsy will be needed since it's a first metastatic appearance, right. Because 15% patient will have a change in receptor status.
Right. So that is very true.
Is a single meds or is a multiple meds?
No, it was multiple bone meds, but there was no visceral met. So Dr. Sandeep Jasuja has also joined here. Dr. Sandeep, how comfortable you are with the bony biopsy with ERPR HER2 assessment?
Same as that. Yeah, I'm totally agree with our colleagues that we should do a biopsy, but the important point is where to get this tissue. And I think when the surgeon did this surgery and prosthesis, might be have taken the biopsy at that time. Important point here is that what is the exact when the anastrozole was stopped, like 1 year before, 5 years, did she receive 5-year anastrozole or how much time?
It was for five years. In fact, after 5 years, we stopped that because she was having a lot of bone pains and she had fatigue also. So after 5 years, we stopped somewhere in the end of 2019. In fact, after around 5 years.
1 year is the off anastrozole hormonal treatment. Might be possible. It could be again ERPR positive like bone mats only. If you cannot have a biopsy from a bony tissue, then we can assume that it is a ERPR positive and HER2 again.
So Dr. Sandeep, if now the reports come as ERPR negative, will you stop the hormone receptor directed therapy at this point if we are repeating the ERPR?
So again, I would question about the where you get this biopsy. If it is from standard laboratory, then I hope 90% it will be again ERPR positive, HER2 negative because of looking at the disease-free interval and stopping the treatment. And again, the presentation as a bone mets, not visceral mets. But somehow, if it is coming ERPR negative and HER2 positive, then the treatment we have to double confirm and we should change our treatment according to that.
Can I make a comment?
Yeah, Dr. Soman.
Even sir,
two things
Yeah.
in my mind, that bone site may be the poor site for the assessment for the ERPR until you have a separate extraskeletal tissue soft tissue component. This patient has responded beautifully to the 6 years to the hormone therapy.
Yes.
So I will call it the sensitive relapse. And only bone mets are there. There are no visceral crisis, no visceral mets. So even if I don't do the biopsy or assessment, or even if the ERPR is negative, I would like to do this treatment at least in the second line, at least with the one line of the hormone therapy, and will assess how long the patient remain progression free.
So I also agree, Dr. Somani, with what you say, that once ERPR positive, we consider that it is ERPR positive. Of course, if it is ERPR negative to begin with, then we wait for any change in this status. Dr. Jasuja, you also agree? Yes, please.
Yeah, totally agree, because even 20% patient, even ERP are negative, having bone mats and especially soft tissue mats, not our visceral mats, also respond to again hormonal treatment, and even we can do for second line or first line treatment, we can choose. That's why I'm saying that it is, looks like a ERPR positive patients. In spite of, I will double sure it is negative or positive if reports come first from a tissue.
Right. So the approach we have discussed. So next comes about the radiation. So we have Professor R.S. Gotwal here with us, radiation oncologist from Medical College Jaipur. So Dr. Gotwal, how about the radiation? Is it always necessary to give radiation, or if my surgeon says that I have removed the disease part and implanted a prosthesis, then radiation is needed or it is not needed?
Sir, first of all, we have to fix fixation, then we give relative RT with zoledronic acid.
My question is, if the surgeon has removed the disease part, pathological fracture part he has removed, and the remaining part he feels that it is okay, it is not disease, so then also we need to do sterilization with radiation, or we can skip the radiation?
We can push the radiation.
Okay, perfect. And radiotherapy has been given to this. And the second thing comes, I'll start with Dr. Ankit now. Ankit, are you there? Dr. Ankit Agarwal.
Sir, good evening. Yes,
yeah,
sir.
Ankit. So Ankit, at this point, repeat biopsy has been done by our surgeon, and again it is same ERPR positive, HER2 negative, and this is confirmed from meds from the bone. So now, how do you select the next line of treatment? She has received 5 years plus anastrozole.
Sir, looking at the case, I think what the patient has progressed within 1 year of stopping our adjuvant treatment. So what I will consider it as a moderate sensitive disease, or the patient will definitely require a target therapy along with fulvestrant. So what I feel is the best thing that we can go ahead with is fulvestrant with a CDK4/6 inhibitor.
Yeah, Dr. Sandeep Jasuda, you also agree to this combination of fulvestrant plus CDK4/6 inhibitor?
So, in my opinion, what we can do is that we can restart anastrozole or AI inhibitors with CDK4 inhibitor, because it's a sensitive relapse. And later on, we can observe the fulvestrant in second line hormone treatment.
All right. Dr. Ajay, you have different thoughts, or you also agree with the AI plus CDK4/6 inhibitor?
Sir, I would go with Dr. Ankit, CDK4/6 inhibitor with fulvestrant.
That anybody has got any difference of opinion here, or everybody feels that out of these two options, AI plus CDK4/6 versus fulvestrant plus CDK4/6 inhibitor? So, any other investigations, mutation analysis, anybody will like to do that? We have done only ERPR, HER2. So any other test you suggest? Dr. Uttam Soni is here. Dr. Uttam, can you discuss what type of mutation analysis you would like to do at this point? Is Dr. Uttam Soni there?
I'm very well here, sir.
Yes, sir. So tell us how do we approach here? Which molecular markers you would like to do? Any testing, special testing you would like to do at this point?
So now that we are talking about a new drug, I think this is the ideal time to get a PIK3 mutation done on this patient with the same tissue that you're taking out for getting a repeat biopsy.
Right.
So that we can have an idea of what the future is going to be like.
So if it comes positive, then how do you approach? If this comes negative, then how do you go?
If it comes negative, then we know that the new drug is not going to work. So if in future there is a relapse, we need to get prepared for something else.
Right.
And if it comes to be positive, then we know that we've got another drug in our arm, which we can use anytime.
So when do you use that? Immediately once we get the report positive?
No. On failure of this, on progression with a CDK4/6 inhibitor.
Perfect. So I think that is very good. Anybody else wants to give any inputs on this, whatever has been discussed? So the question comes, whom to test we have discussed, when to test on progression. Should we test with baseline blocks or should we test separate tissue from the progressive disease? Dr. Somani has also mentioned very well that it is always good to test on the fresh biopsy specimen if possible, or else our archival tissue can be used if it is not available. Even blood also can be a good tool to test if we cannot have the tissue available to us. So all patients with metastatic breast cancer in the context of trial in the clinic offer to ER positive and HER2 negative MBC who has progression on.
Can I put a question forward in front of all the panelists?
Yes, sir, please.
Suppose this patient had the biopsy. Soft tissue component is there, biopsy is done, and that turned out to be ER, PR positive, HER negative. So you would and the tissue used for the this PIK3 mutation also, and that also turned out to be positive at this stage. So keeping these things in the mind, you would like to treat your patient with the fulvestrant with the CDK4 inhibitor or with the fulvestrant plus PIK3 mutation inhibitor.
Uttam has already answered his choice. So now it comes to Dr. Ajay Yadav, if he is there, and then Jitendra.
Sir, my approach will be same. I will treat with fulvestrant plus CDK4/6 inhibitor first. Will preserve the drug for the next time when the disease will
Alpelisib you will
in
keep
the
present
context. In the present context, CDK4 inhibitor plus fulvestrant. Let's say after 2 years, patient progresses.
Then we can.
How you will?
Sorry, we can do the biopsy again at that time.
So how you will partner the PIK3 mutation drug with the any other partner hormone therapy? You have used the aromatase inhibitor also. You have used the fulvestrant also. So is there any thought process that this PIK3 mutation can be analyzed? And based on this biomarker, why not to give the fulvestrant plus PIK3 mutation inhibitor drug rather than CDK4 inhibitor?
So Dr. Ajay.
Sir, if it comes PIK3 positive, then will you skip the CDK4/6 inhibitor?
No, I won't skip.
He won't skip. He says that why don't you use PIK3 inhibitor plus
Sir, may I answer?
Yes,
sir, may I contribute?
Yes, sir.
Sir, I think what we are aiming at is progression-free survival. We are not aiming for a cure. So we need to now what we have, the data that we have in front of us is we know alpelisib can be used after our CDK4/6 inhibitor. We don't have a very strong data to suggest that CDK4/6 inhibitor can be used after failure of alpelisib. So what we can sequence best is using CDK4/6 in first and then going for alpelisib. We can preserve it once we have a progression on CDK4/6. And if the patient, for example, if the patient progresses after 2 years of fulvestrant and CDK4/6, we still know that he might have some moderate sensitivity to the hormone drugs. So what I will do is I will continue fulvestrant and add on alpelisib to the to fulvestrant once CDK4/6 fails.
There are
may interfere?
Yeah.
For this patient is typically same as the Parsifal trial. In this we took the hormone sensitive patient and in this fulvestrant is not superior to AI inhibitors, then why we cannot use CDK4 inhibitor with AI again, as the Dr. Sandeep Sousa said, and then we preserve fulvestrant and alpelisib both for after failure.
Sir, even
Because it is proved that this type these type of patients there is no benefit of add the fulvestrant on another AIs with the CDK inhibitor.
Yes,
So
totally
we can
agree, sir.
use,
That's why I'm saying, yeah. Even you have written down here that ERP are positive, HER2 negative, amnesty progressing on AI plus CDK. It's not a one. Yeah.
we can preserve both fulvestrant and alpelisib for the next line. One thing is that, and second
I
thing,
think
when
there are
we have one
yeah.
mutation and one targeted drug for this, then how we can say that we put this drug for next line, because we do not have any trial that the alpelisib failure on alpelisib CDK4 inhibitor are not
Dr. Surender, Dr. Beniwal, this scenario applies only when your patient is progressing on the tamoxifen. Due to any reason, if the patient is getting tamoxifen, then you have the opportunity of giving the aromatase inhibitor plus CDK4 inhibitor.
No, sir. In
The
particular
patient,
trial, there is patients who have failure on AIs, but there is only condition that they are hormone sensitive. There are at least 12-month gap, or they are hormone naive.
Our patient is not very sensitive. He has progressed within 1 year of stopping adjuvant treatment.
After 12 months, if there is progression within one year, then we have to give fulvestrant.
Yes,
So,
yes.
so what the outcome is coming is very good. Ankit and Surinder has brought very good points that this patient has progression of disease within 1 year of the stopping of aromatase inhibitor. So adding AI again with any partner drug will not be that robust idea. And since many things are confusion and yet we all are in learning phase, so I think this is a very good discussion point. And even at the international platforms, there are no consensus to many of these common questions. So these are the timing we have discussed, and this is what NCCN suggests. The PIK3 mutated, they are saying this the second or subsequent line therapy. Additional agents can be agent rather than upfront, in fact, immediately on progression. So this all we have discussed. PIK3 we have discussed. So the next, like for our patients, we agreed for fulvestrant only because CDK4/6 inhibitor they could not get, and technically this patient has some insurance also. So once she got admitted, then the things were reimbursed, and the oral drugs were not getting reimbursed. So due to this technical reason, we were able to use fulvestrant on her. So the question comes: if she would have been a premenopausal lady at this point, how different your approach would have been? So I'll start with Ajay Yadav again.
Sir, I would go for ovarian suppression first, and the approach would be the same as CDK4/6 plus fulvestrant.
Very right. Dr. Ankit, you also agree that for the premenopausal, we make them ovarian function suppression, maybe permanent, temporary, whatever, and then we treat them like postmenopausal only.
Yes, sir. Yes, sir. I think we have we should offer ovarian suppression to all the premenopausal ladies.
Right.
Yes, sir.
And the another criteria for selection remains comorbidities, concomitant drugs, and the availability, of course, remains one of the major challenge. And I think whenever we select any drug for any patient, these are the 4 each we keep in mind, that efficacy remains topmost. Then comes the evidence for efficacy. Third important point practically is economy, and then comes the ease of availability as well as administration. So this patient was started on fulvestrant plus zoledronic acid plus local RT, and she sailed through reasonably well, but she had again after RT she had lot of GI complications which lasted for more than 1.5 months. During the lockdown phase she was in troublesome diarrhea repeated, and that was managed with whatever way. And few days back this lady has come to us again with documented hepatic mets plus bone mets have also progressed. So at this point, how do we approach here? So Dr. Sandeep Jasuja, may I start with you that how do we go ahead now? She had within 6 months she has progressed.
So basically, it's now hormone-resistant disease, and we should go for second-line treatment. Like now, one more option we have, because in this hormone-independent progression, we may have these mTOR inhibitors. We can add mTOR inhibitors in this patient. Absolutely, yeah, totally agree. We should go for this test, pick-a-3 test, and 40% patient may have this positivity in this patient. But
Yes.
still, if they are not eligible candidate, we can add mTOR, and that also break the resistance of hormones resistance.
Can I ask a question, Dr. Jasuja?
Yeah, please, sir.
Yes, sir.
Suppose this patient had the 6 months of the fulvestrant and progressing, and PIK3 mutation is positive. Would you like to add the alpelisib with the fulvestrant at this stage?
So, sir, basically, if hepatic mets, the important point is first, I assume this is patient is asymptomatic from liver functions.
She is not in visceral crisis.
She is not in visceral crisis. Yes.
So yes, we have both option, and the standard now. What we are saying is, what we are discussing is that we can add in fulvestrant. That is the also one of the best option. But if we cannot add because of financial constraint, then everolimus is also very good option. mTOR inhibitor adding with the fulvestrant and this also.
Dr. Shivank Mathur is with us. He is a surgeon. Dr. Shivank, is there any role if there is solitary hepatic met here? Is there any role of removal of any metastectomy at this point or anywhere in the management of metastatic CA breast?
If there is a single solitary met, a single metastatic hepatic metastasis, we can go for a surgery, or we can go for a gamma knife surgeries or a radiation ablation. But if there are multiple mets and the liver enzymes are deranged in these patients, then we have to continue with this PIK3 mutation inhibitors along with the fulvestrant.
Agreed. I think very, very important point. So rebiopsy at this point, again, she had second progression. So will you consider for a rebiopsy again after say progression in the liver mets plus bone mets? Dr. Shivank, can you clarify that?
Sir, since we have taken the biopsy in the February,
yes,
probably there is no need for it. But if it is accessible, we can consider in a image-guided biopsy or a true-cut biopsy like that.
So in fact, this patient did not agree for biopsy, but any other NGS or any test you would like to do? Dr. Uttam Soni is here. So Dr. Uttam, any role of NGS or any mutation at this point? She has rapid progression.
At this moment of time, I will refer this patient straight away to you.
Okay. And you will not advise for any
I
test?
will not advise this patient anything. No. This is out of my field now.
Okay. Dr. Lalit Sharma has also joined us. Dr. Lalit, are you there?
Yes, sir, I'm there.
So can you throw some light at what type of mutation test or NGS, anything you would like to do at this point?
Well, so first and foremost, if we haven't done a PIK3CA mutation on the earlier sample, definitely a rebiopsy is indicated. But also to look for any other targetable mutations such as NTRK mutations, we can definitely go ahead with the NGS to look for any targetable therapy, options of the targetable therapies.
So Dr. Ajay, you also agree that you will advise for full panel of NGS or selected mutations you will advise. Finances are not a barrier.
So if we are starting PIK3 inhibitor, then I would not advise NGS. I would start the treatment on the basis of.
May I ask one question?
Yes,
please?
yes, Dr. Sandeep, you can answer only because you are a panelist, so you can answer the questions.
Because in this case, why you have not added CDK4 inhibitors apparently in this patient?
Yeah, the answer to that I wanted to add, I discussed with the family, but they had some insurance issue and the insurance company did not allow for the oral therapy. So the hormone therapy was injection after admission, so it was allowed, and that was honestly the reason of not using CDK4/6 inhibitor.
So still we have this reasonable option with us to start again?
Yes, I think that is also one option, CDK4/6 inhibitor. But how about the partner drug at this point?
So because actually this is hormone independent drugs now, and even have no data to start in the hormone independent mutation metastatic. But still CDK4 is a different kind of mutation, different kind of mutation or regulator gene where we can act, and still we have a reasonable option along with the fulvestrant at this point also.
Good. Anybody else wants to add to this discussion here?
And
so if the patient had, if she would have been on CDK4/6 inhibitor, say rather than fulvestrant, she could have been on CDK4/6 inhibitor. So is there any role of continuing CDK4/6 inhibitor beyond progression if she would have progressed within 6 months? Is Dr. Mukul also connected? Dr. Mukul needs to go somewhere, so he might be in journey. So Dr. Mukul, are you there to contribute? Dr. Ajay, can you address? Probably Mukul is not able to connect. So
Sir,
is there
it's
any
true.
role of CDK4/6 inhibitor beyond progression?
That depend on the number of the metastatic disease. If there are single or one or two metastases in the brain, then we can deal these metastatic site with radiotherapy and we can continue the CDK4/6 inhibitor. If the disease burden is high, then we have to change.
Can I add another point here?
Yes, sir. Yes, sir, please.
Out of 3 CDK4/6 inhibitors, abemaciclib is the only one which has the single agent response rate and activity, and approved also for that point of view. So if you want to re-expose your patient, those who has been given previously the CDK4 inhibitor, suppose you don't want to give chemotherapy, then maybe that you can re-expose your patient or re-challenge with the single agent abemaciclib. So I would like to answer this point or make the comment here in a different way, that abemaciclib has some single agent activity.
Very right, and very good point. Dr. Ankit, what are your views on continuation of CDK4/6 inhibitor in a patient who has progression of the disease? You would like to change the partner drug?
Sir, I think it's better to get a PIK3 mutation testing and then decide on changing the CDK4/6. The patient has progressed within 6 months, so I will not be very comfortable in using CDK4/6 beyond progression.
Very right. So this patient's CDK4/6 analysis has been awaited, and the available option at this point is chemotherapy plus hormone therapy, continuous CDK4/6 inhibitor plus change the hormone partner. Everolimus, Dr. Sandeep Jasuja has mentioned, is very good drug, and probably we are less using and less focused, but this is good drug, and probably if patient accepts and tolerates this drug, this becomes a good partner. However, this R patient not willing for IV chemotherapy, this we have discussed, I think. And this patient did not agree for a third biopsy here from hepatic asshole. We also did not insist. So this also the point has been discussed by Dr. Shivank and everyone. So this has also been that if the wax block, we cannot procure the fresh tissue, we can do the biopsy on the old wax blocks, archival wax blocks. I'm not very sure if any of you can throw light that is it rather than say waiting for the progression to happen and then doing the PIK3 mutation test, can we do it baseline also along with ERPR, HER2 so that whenever progression happens, we can keep this drug in our hand? Dr. Ankit, you want to say that?
Yes, sir, I think it's a good idea to get it done at the baseline only when we are getting the ERP or HER2 IHC. So that we have the drug in our hand, we know what our plan is further if the patient progresses on CDK4/6.
Dr. Ajay, you also agree that baseline only we can ask for the PIK3 mutation test rather than waiting for the progression?
Yes, sir, we can ask.
I think the guidelines again suggest that it is always good to do it on the fresh biopsy on progression of the disease. If you cannot do that, try to do it in the blood. If you cannot do that, then you can do it on the old archival tissue. But again, it is valid option that we can do it on the old archived tissue also.
There is approximately 20% incidence of the PIK3 mutation in the early breast cancer. So it can be done, but obviously the fresh tissue is always better at the time of the progression or relapse.
Right. So it is said that almost 35–40% of the patients might be harboring this mutation, which now targetable drug is available. And we all know by this time that who should receive alpelisib. The next question comes, how do we test for the PIK3 mutation? And I think this will be beyond scope of discussion in this panel. Dr. Somani, can you throw some light on the methods of testing for PIK3 mutation?
No, nothing much from my side. You have already just summed up that the fresh tissue at the time of the progression is probably the best. The blood is alternate. If not, then maybe the old tissue at the time of the progression, or otherwise during the early stage breast cancer when you have done the surgery or you have done the biopsy, that can be taken. If the positive means it's the positive, but negative doesn't mean that it's a negative.
Very right. So the FDA has approved companion diagnostic kit. Again, this type of PCR kit on tissue or on blood. On the blood also and tissue also it has been approved, and this is in NCCN guidelines also, that we can use the blood as well as we can use the tissue for determination of this test. And these are the methods which I think sometime later we will have some scientists with us who can throw light on various platforms, that what are the plus minus points of doing these tests on different platforms. And I think this is again that we have discussed that patients who are endocrine therapy naive progression of more than 1 year, Dr. Somani has shown in one of his slides. But again, we can see that PIK3 CA mutated patients, alpelisib remains an option in patient with high endocrine sensitivity, in patient with moderate endocrine sensitivity, and even in patients who have poor endocrine sensitivity. So at each point, the alpelisib has got a role, and probably we will be in coming few years, we will be having more and more experience of using this drug. Then we will have our own sort of database to prove that this drug, and we don't know that tomorrow this drug may be coming upfront also somewhere rather than waiting at the end. It may show some partner drug with improvement in overall outcome of these patients. This Dr. Somani has already shown in his slide, and this is again the same thing which has been described in different way. But again, the important point we should note here is also that the everolimus has also been used in patients in all the groups also, and everolimus is easily available, cost effective, and we use it less often. In fact, probably we all have fear of having severe side effect with that, but that is option we should keep always open. These are the summary question, that common question, why test? So this is here. When to test also we have discussed, what sample is to be tested, which mutation is to be tested, and then comes the how to be tested, PCR or NGS technique. So we conclude that PIK3 mutation tests are most common mutation in ER positive breast cancer. We should test in patients who are hormone receptor positive, HER2 negative, MBC on progression of the disease. What to test? Tissue is preferred, but again blood also can be used. So both in blood as well as in tissue we can do this test. And the way forward looks the treatment of PIK3 mutant patient, HER2 positive or triple negative. Also, like Dr. Somani also mentions that few patients, even those who are hormone receptor negative, they may also be having PIK3 mutation, and we yet don't know about this question. But HER2 positive, triple negative, that this is found in this subset also. Positive combination with CDK4/6 inhibitor, PARP inhibitor, or combination with immune checkpoint inhibitor is yet under study, and there are certain newer molecules. So I think with this, I'll end up here and request the participants and the esteemed faculty member to give their any comments about this discussion. Anything, any point they want to add up. Dr. Sandeep, you want to communicate as last take-home message?
I think, yeah, Doctor, anybody wants to make a comment? Otherwise, we invite Dr. Pawan Agarwal to conclude today's presentation and to give us some message about today's meeting. Dr. Pawan Agarwal is here. Dr. Pawan Agarwal, are you here?
He's,
Okay. Yeah.
yeah, he's
Good
there,
evening.
sir.
Good evening, everybody, and thank you, Dr. Naresh Somani. And this is a wonderful presentation and all ours. And I listened from starting to end. And I think there is no concluding remark over Dr. Lalit Mohan presentation on concluding style and everything he has covered. And my lot of panelists, esteemed panelists, has did fruitful discussion among Lalit Mohan. And before that, Dr. Somani has taken so much pain and make this meeting grateful. And there is also, I would like to extend my thanks to the company, to the participant, and Dr. Malhotra, who have give a blessing from start and start the meeting. And after that, Deepa Gupta introduce the topics and make the scenario to start what we are going to listen today. And Dr. Somani unfold the story, each and everything, how we can do. And the clinical aspect, Dr. Lalit Mohan Sharma has covered everything. So with this, I conclude, or I finish the meeting today, and hope soon we meet again in a week or two.
So can I have a comment and request to all of you?
Yes, sir, please.
So I appeal all the participants here and through this meeting to all the members of the Rajasthan Oncology Group. Two important webinars or CME or the international CME are lined up with us. That is we are having the SARC Association meeting on the 29th and 30th being organized by us. And then Dr. Jasuja is making in the next month the much talked, that is the IBCC Precision Oncology meeting. So I request all of you that we actively participate in these meetings and other meetings where especially the doctors from the Rajasthan Oncology Group are arranging, making, or being seen or being as the faculty members. With this, I thank all of you for today's meeting, and once again thanks to the sponsor Novartis and Mr. Tarun from the Horizon to have the smooth conduct of the today's meeting. And I think with this, we are more clear in the management of the hormone receptor positive metastatic breast cancer. And if no more comments, then can we close today's session?
Yes, we
Thank
can.
you, sir. Thank you.
Thank you, sir.
Thanks
you,
and
sir.
good night and stay
Good
safe.
night. Good night. Take care. Stay safe.
Thank you.
Thank
Bye-bye.
you. Thank you, sir. Thank you, Dr. Sapati, for the kind words. We close the meeting now.
Ronak, we can close the meeting now. Ronak, close the meeting.